Welcome to Health Matters, brought to you by the Office of Correctional Medicine at Southern Illinois University School of Medicine. This video is for informational and educational purposes only. It is not intended as medical advice and should not replace consultation with a qualified healthcare professional. Always seek the guidance of your doctor or other licensed medical provider regarding any questions you may have about your health or medical condition.
Hi, I'm Dr. Chris McDowell. I'm an emergency physician. I'm here to talk with you today about risk stratifying chest pain in correctional medicine centers. I work in the emergency department. I've got access to the latest technology in my emergency department and access to the cath lab with my cardiology colleagues who can get the right care for you when you need it in the hospital. But your environment probably looks a little bit different. You might have a clinic exam room or a small ambulatory care setting that looks more similar to this. And I recognize that that's a very different environment. So we're going to try to tailor this conversation so that it really fits the needs that you have thinking about this from a correctional perspective and the type of access to facilities and modalities from where you work day in and day out. So let's start with some take-home points. Let's go over the definition of acute coronary syndrome. So these are the things that actually need cardiac intervention. These are ST elevation MIs, non-ST elevation MIs, or unstable angina presentations. Those are things that need to come to the hospital and may actually need emergent cath lab activation. We're going to talk about the heart score and how to use the heart score to actually assess someone's risk in whether or not they have a possibly cardiac cause of their chest pain. And when in doubt, if somebody has an abnormal EKG, they just need to be sent to the hospital for evaluation. New EKG changes and a worrisome story, they need to be sent to the hospital. So let's move forward and let's think a little bit about this as an urgent care provider. I realize that you work in an environment where you may not be able to do labs. You may not be able to get cardiac enzymes. You might not be able to give aspirin, nitroglycerin, or start a heparin drip where you work. But you can do things like get the EKG. You can use the heart tool to stratify somebody for acute coronary syndrome and their risk for a cardiac cause. You might be able to give them aspirin in your environments. When I was a kid, on Monday Night Football, IBM would do this thing called You Make the Call, where you actually got to see the replay and make the call and see if the official got it right. So I want to do a You Make the Call session with you here today so that we can get some practice in how we actually risk stratify chest pain presentations. Our first case, a 65-year-old male who presents to your facility and a concern of heavy chest pressure, they're diaphoretic, and they've got pain down their arm. They've got a significant past medical history for coronary artery disease, hypertension, hyperlipidemia, and diabetes, meaning they have multiple risk factors. As the patient's describing his symptoms, so they hand you this EKG, and right away, you see that it's abnormal. There's ST elevation along the anterior wall of the heart, and you know that they're having an anterior ST elevation MI. So what does that mean for you? What happens with this patient? What's the disposition? You got it. This person needs to be transferred for emergent cath lab activation and PCI at the nearest capable facility. Great. So let's talk a little bit more in depth about the heart score. The heart score is a risk stratification tool that most of us use in emergency medicine every day. And you can see that the elements of the heart score are the history, the EKG, the age, risk factors, and then the actual value of the troponin itself, making the acronym HEART. We use the heart score to basically risk stratify a patient's presentation, taking into account their history, their EKG, their risk factors, their age, and their troponin to decide what their risk is long term. We break this down into low risk, 0 to 3, moderate risk, 4 to 6, or high risk, greater than 7. We know that in somebody that has a low risk heart score, their risk of a major adverse cardiac event is 0.9 to 1.7%. Very low risk, safe to go home. For people that have a moderate risk score of 4 to 6, they actually have a major adverse cardiac event rate of 12 to 16.6%, and they may benefit from observation or admission to the hospital. And then, of course, those individuals that have a high risk score of 7 or above, Well, their risk of a major adverse cardiac event is 50% to 65%. So we know that they are very high risk and definitely need to be admitted to the hospital for further evaluation. The reason we care, the risk of major adverse cardiac events, which includes acute myocardial infarction, PCI or emergent cardiac cath lab activation, CABG, bypass surgery, or death, varies significantly by the score. So let's go back to that first case now and break it down. 65-year-old male with heavy chest pressure, diaphoresis, and arm pain, with significant past history of coronary artery disease, hypertension, hyperlipidemia, and diabetes with an abnormal EKG. So let's look at their heart score. By history, I would say this was a highly suspicious presentation. They get 2 points. For their exam, or their EKG, we see that they get 2 points for significant ST deviation. Their age, they get 2 points because they're greater than 65 years of age. And for risk factors, they get 2 points because they already have a history of coronary artery disease. My point is, this person's high risk before we even get their troponin back. So you could make that determination in a care center and decide somebody needs to go without having access to any of the troponin values and actually know that they need to seek care at a local emergency department. So as you're aware, an ST elevation MI goes through several phases on the EKG. It starts with hyperacute T waves. Then we develop ST elevation. Then Q waves start to develop over a period of more time. Eventually, the ST elevation, Q wave, and T wave inversion, which might last as far out as even 5 days until it just resolves to Q waves moving forward. Those are the things we're looking for when we're looking for an abnormal EKG. Let's do another case. This time we have a 48-year-old male who presents with a complaint of chest pain. He's got pressure across his chest during activity, and he's got pain now that's 4 out of a 0 to 10 scale. His past history is significant for hypertension and hyperlipidemia, and he takes appropriate ACE inhibitor therapy for his hypertension and torvastatin for his hyperlipidemia. When we review his EKG, it shows some abnormal changes in the lateral wall of the heart, suggesting that he's having a presentation maybe of an acute coronary syndrome as well. With that lateral ST depression, what should we do with this patient? Well, let's go back and ask you to make the call. This patient too needs to be transferred to the emergency department because they have a high-risk presentation with a high heart score and somebody who's at risk to have acute coronary syndrome and needs further evaluation. So let's break that down by heart score. Their history, they get 2 points for highly suspicious. Their EKG, they get 2 points because it's abnormal. Their age, they get 1 point because they're 48 years old. Their risk factors, they get 1 point for the 2 risk factors of hypertension and hyperlipidemia. So we know that their total score was 6 or at least moderate risk before we even got a troponin value back. Again, worrisome story, moderate risk, somebody who benefits from seeking care in the emergency department. Let's move to another case. This time you have a 23-year-old male who presents with reproducible chest wall pain, meaning when the clinician pushes during an exam, it reproduces the pain that brought the patient to be seen in the first place. Their pain only occurs with palpation. They have no exertional symptoms, they have no associated shortness of breath, no associated diaphoresis. Their past medical history, as you might hope at 23, they're healthy. They have no cardiac risk factors, no family history of disease, no hypertension, no hyperlipidemia, no diabetes, and they don't smoke. So let's look at their EKG. When you examine this EKG, it looks like normal sinus without any signs of ischemia or suggestive of acute coronary syndrome. So now let's break down what their heart score would be. Normal ST segments, no Q waves, no acute changes. This is probably a low-risk EKG. So let's look at what their heart score is when we break it down by score. Again, 23-year-old, so age is going to be less of a concern. It's reproducible chest pain as opposed to exertional pain or pain that's accompanied by shortness of breath and diaphoresis. They're healthy, they've got no risk factors. So when we do their heart score, they get a 0 for history, non-worrisome story. Under EKG, they get a 0 because they have a normal EKG. For age, they have a 0 because they're less than 45. And for R, they get a 0 because they have no risk factors. So this is a very low risk presentation of chest pain. So let's summarize again where we've been. We talked about the things we have to watch for with chest pain and my take-home points. Acute coronary syndrome. We're looking for ST elevation MIs, non-ST elevation MIs, and unstable angina presentations. We know that heart scores greater than or equal to 4 have at least moderate risk, which means a major adverse cardiac event of greater than 12%. We've talked about a newly abnormal EKG and concern for a heart disease presentation, that patient just needs to be sent to the emergency department for evaluation. And any patient who has a history of coronary artery disease that has a worrisome presentation, without doing any additional testing, they should really be sent to the emergency department for evaluation as well. I hope this gave you some idea of how we can use the heart score to risk stratify patients and understand what you can do in your care environment to get patients the right care every time.